Ayun, let's start off with our lecture 14. Present ko lang po yung slide. Makikita naman po ng lahat. Ayun. Ayan, so let me just introduce the first lecture session for today. Is all about metabolic changes among people living with HIV and long-term antiretroviral therapy. So our expert is a member of the Institutional Review Board reviewing research protocols for Makati Medical Center. And she's also a member of the board representing the Philippine Society for Microbiology and Infectious Diseases. She is also an assistant secretary and member of the board of the PLHIV, the head of the Infection Prevention and Control Department of MMC, and the chief for the section of infectious diseases in the Department of Medicine. And just to emphasize that she is also one of the fellows who were sent to the Arthur Ashe Endowment's International Healthcare Program in Weill Cornell University in New York City. It is an honor to have our expert to discuss metabolic changes among PLHIV and long-term ART. Let's all please welcome Dr. Janice Caoili.
This one. Yeah, perfect. Doc, ito na po siya.
Okay. Okay. You can still see my notes?
Okay na po, Doc Janice.
Okay, so thank you again, Kate, for inviting me to be part of your lectures for this year. And I'm tasked to discuss management of dyslipidemia among patients with HIV, which is the most common metabolic disorders among our patients with HIV who are on antiretroviral treatment. Okay, next slide. Okay, there. So these are my disclosures. And at the end of my presentation, I hope that you would all be able to describe the risk factors for cardiovascular diseases among HIV patients and to at least know the step-by-step guide for the evaluation and management of dyslipidemia in patients infected with HIV. So in resource-rich countries, the annual mortality of patients living with HIV has now decreased to less than 2%, and that's due to effective ART. So patients in these countries are dying from non-AIDS-related events such as cardiovascular diseases, surpassing deaths due to opportunistic infections. Although we still cannot appreciate this in our setting, we anticipate that this will be a trend in the future and that CVD will eventually be the leading cause of morbidity and mortality among our patients with HIV. More and more studies all over the world now show that HIV infection is associated with an excess risk of cardiovascular disease, including acute MI, other ischemic heart disease, and coronary atherosclerosis. Patients with HIV infection are observed to have 1.5 to 2-fold increase in the rate of cardiovascular events as compared to the general population. And in the latest WHO guidelines in the management of patients with HIV, it was mentioned that large cohort studies have confirmed that the risk of both myocardial infarction and cerebrovascular disease is 40 to 70% higher among people with HIV than among age and gender-matched HIV uninfected controls. So this association has been reported both in people on ART and in those who are treatment naive, and among adults, adolescents, and children. Since our patients now live longer on ART, it is very important for HIV clinicians like us to identify and initiate preventive interventions, since most patients would eventually warrant treatment of modifiable risk factors for CVD. So several factors have been identified to increase the cardiovascular risk among patients with HIV. So among patients with HIV, dyslipidemia, insulin resistance, body habitus changes associated with HIV, and use of certain antiretroviral drugs, increased prevalence of smoking, and prolongation of survival due to effective ART are factors identified to increase risk for cardiovascular disease. The degrees to which each risk factor contribute to the elevated risk of cardiovascular disease in the HIV-infected population remain an active area of investigation. On the other hand, effective control of viral replication through effective ART has been shown to have beneficial effects in decreasing incidence of myocardial infarction. Use of ART in suppressing viral replication reduces inflammatory markers and immune activation that has been implicated as triggers for an inflammatory state predisposing HIV patients to have cardiovascular diseases. There are now newer ARVs that have more favorable effect on metabolic and morphologic changes of body habitus compared to earlier ARVs. And HIV providers are now more aggressive in assessing risk for CVD and in initiating measures to modify risk factors, including provision of treatment for hyperlipidemia. And these are all factors identified to decrease the risk of cardiovascular diseases among HIV patients. Certain antiretroviral agents have been associated with greater risk of cardiovascular events, such as older generation protease inhibitors, such as indinavir, and of course, lopinavir and ritonavir. Although indinavir is not part of the current treatment guidelines in the Philippines, lopinavir-ritonavir is still part of the second-line ART regimen in the country. Lopinavir-ritonavir has been shown to increase the levels of total cholesterol, LDL-C, and triglycerides among patients taking this medication. And although to a lesser extent compared to the protease inhibitors, non-nucleoside reverse transcriptase inhibitors, such as efavirenz, etravirine, nevirapine, rilpivirine, also affect levels of lipids. The latest HIV treatment guidelines in the Philippines still utilize efavirenz as the NNRTI component of the first-line ART regimen and lopinavir-ritonavir as the PI component of the second-line ART regimen. And the latest DOH guidelines now includes a section on monitoring ARV toxicity that includes assessment of lipid profile within 6 months, then every 12 months, or as needed. So dyslipidemia refers to any abnormal serum lipid level. And there are many different lipid particles. The cornerstone, though, of lipid therapy has traditionally focused on low-density lipoprotein cholesterol, or the LDL, due to its association with cerebrovascular disease. The lipid profile that we usually request for our patient includes measurement of total cholesterol, there, the high-density lipoprotein cholesterol, the computed low-density lipoprotein cholesterol, and triglycerides. The 2016 WHO HIV treatment guidelines included a recommendation that assessment and management of cardiovascular risk should be provided for all individuals living with HIV according to standard protocols recommended for the general population. The guidelines mention that there are no established and comprehensive guidelines for management of dyslipidemia for patients living with HIV. Therefore, guidelines for the general population should be followed, keeping in mind that guidelines for the general population may underestimate the CVD risk among HIV patients. Because of unavailability of recommendations specific for the HIV population, a group of HIV experts based in the US published an article entitled Management of Lipid Disorders in Patients Living with HIV, with the objective of providing guidelines for the diagnosis and management of dyslipidemia to the clinician taking care of patients living with HIV. So the authors of this article propose a step-by-step guide for the evaluation and management of dyslipidemia in patients infected with HIV, starting with step 1, which is to assess the cardiovascular risk and presence of metabolic syndrome according to the National Cholesterol Education Program Adult Treatment Panel 3, or the NCEP-ATP3 guidelines. Patients can be classified into any of the 5 risk groups: very high risk, moderate high risk, moderate risk, low risk. And risk stratification is needed to determine treatment options as well as your targets for LDL-C, aiming for lower targets for those with greater risk. Okay, can you see that? Or it's too dark? But anyway, you can download the article of Meyerson. It's available online. The article of Meyerson et al. Provides a table on how to determine the risk category of HIV patients based on clinical and laboratory parameters. So we identify patients who are very high risk. So these are usually patients with known coronary artery disease or cerebrovascular disease or even a peripheral vascular disease, plus one of the following. So please note that diabetes is a factor considered to be high risk for coronary heart disease. And others would include abdominal aortic aneurysm, chronic kidney disease, and also the Framingham risk score. So the Framingham risk score scores patients based on certain parameters, and the score that will be computed is the risk score for coronary artery disease over the next 10 years. And there are also other variables that we need to note, like the age group of the patients, the HDL, or the high density lipoprotein, whether the patient is actively smoking, has hypertension, and also family history of coronary artery disease or cerebrovascular disease, and the presence of metabolic syndrome. So later on, I'll discuss what the criteria for metabolic syndrome. So we can, based on this information, we can actually identify our patients as either very high risk or high risk, moderate high risk, moderate risk, or low risk. Okay, and the clinician may increase one risk category based on clinical judgment. So the author suggested that until specific risk factors and scores are validated for patients with HIV, consideration for increasing one risk category may be reasonable. So if your patient is low risk, you can actually score them as moderate risk if they're HIV positive. So this is the components of the metabolic syndrome. And presence of metabolic syndrome is a risk factor for cardiovascular disease and should be part of baseline assessment. So this table details the component for identifying patients with metabolic syndrome. So abdominal obesity, so depends if your patient is, of course, most of our patients are Asians. So you can see that there's actually an adjustment. For Asians, the waist circumference is lower compared to non-Asians. And for HDL-C, so there's also a different level for men, different level for women. For triglycerides, please note that this should be fasting triglycerides, blood pressure, and fasting blood sugar. So if a patient has metabolic syndrome, that's already a risk factor for CVD. So there are also mobile apps that you can use, and these are freely downloadable to estimate the risk of CVD. And these apps may be more convenient for physicians to use for assessing the risk of their patients. The apps also provide therapeutic options for hyperlipidemia, as well as targets to be monitored during treatment. So after assessing the risk of your patient, we now go to step 2, which is to establish your LDL-C targets of therapy based on the risk category of the patient, of course, aiming for lower targets for those with greater risk for cardiovascular disease. So you look at the for very high risk patients, the LDL target is very low, less than 70. So maybe when you go back to your patients' cases, you can look at their LDL-C. Most of our patients may be moderate or moderate high, and the LDL targets will be less than 100 and less than 130, respectively. So most patients will present with abnormal levels of several lipid components. So patients can present with a high LDL, low HDL, high triglyceride levels, which is really the most common that we see among our patients. The NCEP-ATP3 recommends achieving an LDL-C target as first priority unless the triglyceride is greater than 500 milligrams per DL at baseline. So if the triglyceride level is very high, 500 milligrams per DL, then the first priority is to lower the triglyceride to prevent pancreatitis. After triglyceride levels are below 500 milligrams per DL, then we can reevaluate the LDL for appropriate management as indicated. So after determining your targets for LDL-C, step 3 is laboratory evaluation. So the core of a lipid exam consists of a fasting total cholesterol, the calculated LDL-C, HDL-C, and triglycerides. And as we mentioned earlier, when triglycerides are greater than when you do your laboratory exam, when triglycerides are greater than 400 milligrams per DL, the calculation for LDL-C is inaccurate. So we should correct first the triglycerides, and then we should determine again the LDL-C levels after we've corrected the triglycerides. Okay? And then step 4 is now clinical intervention. First, the most important is really therapeutic lifestyle change. We should advise this to all our patients regardless of their level of risk. So this would include diet. So we reduce the intake of saturated fats to less than 7%, total calories, and intake of cholesterol to less than 200 milligrams per day. And we might need to refer our patients to a nutritionist for proper advice regarding their caloric intake. But what we usually tell our patients, and what I do in my clinic, is to just look at their plate. 50% of the plate or half of the plate should be vegetables. 1/4 of the plate should be protein, and 1/4 should be carbohydrates. So we should really advise our patients to take in more vegetables and less intake of sugar and fat. Weight reduction is important. Increased physical activity is also important, and we should always advise our patients to stop smoking. So for medication, it's really dependent on the risk assessment and the targets that we set for our patients. If we need to give medication, statins or HMG-CoA reductase inhibitor are the most widely used and researched medications for the treatment of dyslipidemia. Statins primarily lower LDL-C, have a modest effect on raising HDL-C and lowering triglycerides. So in addition to statins, statins also improve endothelial function, it decreases platelet aggregation, it reduces inflammation, and they have been proven to decrease the risk of MI by 20 to 30% among patients with increased risk for CVD in the general population. So Table 9 provides a summary of the interactions between ART and statin drugs. So ritonavir is now used as a second-line ART in the Philippines, is a potent inhibitor of cytochrome P453A isoenzymes, or the CYP3A4, and is used as an enhancer for other PI. So we use ritonavir to enhance the effect of lopinavir in our guidelines, when we treat patients. And for patients on lopinavir-ritonavir, use the lowest starting dose of atorvastatin and titrate carefully, okay? And there are other statins like simvastatin, which has an extensive fast metabolism by CYP3A. So we should not use simvastatin for patients on protease inhibitors, okay? So the FDA recommends a maximum dose of rosuvastatin, which is another statin that we use for patients, and that's 10 milligrams daily when we co-administer them for patients on lopinavir, okay? Some statins also may have significant drug interactions with NNRTI. So these are the efavirenz, nevirapine, rilpivirine, etravirine, resulting in increased or decreased lipid-lowering efficacy. So nevirapine is a selective inducer of CYP3A, and efavirenz is a mixed inducer inhibitor of CYP3A. So efavirenz decreases simvastatin AUC by 58%, and atorvastatin AUC by 43%. So therefore, higher doses of these statins may be required to achieve target lipid levels. Okay. So we also have to monitor the side effects of the statins when we give treatment to our patients. Important to do a baseline testing of AST and ALT before we start treatment, and then we repeat AST and ALT in 1 month. If the baseline or follow-up AST, ALT are elevated, but less than 3 times the upper limit of normal, we have to check the bilirubin. If the bilirubin is normal, you can actually continue your treatment using statin. However, if baseline or follow-up AST and ALT are more than 3 times the upper limit of normal, statin therapy should not be initiated or continued until further workup is performed. And you also have to monitor other symptoms such as muscle soreness, that's very common among our patients, some neurologic concerns like memory loss, and also diabetes. Okay? It is not known if patients with HIV, where insulin resistance is more prevalent, have greater risk for developing manifest diabetes due to statin use. It is recommended to assess for risk of developing diabetes prior to starting a statin and monitor for changes in blood glucose and HbA1c while on treatment with statins. Okay, so other drugs that we can use for elevated LDL-C are the ezetimibe or intestine absorption inhibitors, niacin, but sometimes the side effects are really not acceptable for our patients. And the bile acid sequestrants like cholestyramine have not been evaluated for use among patients with HIV. And how about hypertriglyceridemia? Okay, so we should also advise our patients lifestyle modification. That's the most important. And then cardiovascular risk reduction through interventions such as weight loss. So in obese patients, you have to advise them to try to really lose weight, aerobic exercises, avoidance of concentrated sugars, strict glycemic control in diabetics. And if the triglyceride level is more than 500, medication is already indicated. So the pharmacologic treatment for hypertriglyceridemia includes the use of fenofibrate. And of course, we always advise our patients to use the fish oil. Fish oil, you can actually get that from Healthy Options. That's where they usually buy fish oil. And a high-dose niacin can also be advised for patients. But fenofibrate is the most usually prescribed medication for elevated triglycerides. Okay. Step 5 is now to assess response to therapy. The maximum LDL and triglyceride lowering is evident by 6 weeks after starting therapy. And if patients are not at goal, you can titrate your medications or add a second drug and recheck lipid levels in 6 weeks. Okay. The authors of the guidelines that I mentioned emphasize that given the complexity of care for patients living with HIV, side effects of medications, problems with adherence to a multi-drug regimen, and comorbidities that impact on lipids, it is important to consider that patients may not reach goal for LDL-C or triglyceride. And viral suppression is generally considered foremost, although treatment of other conditions may also merit priority. Okay, so we are almost at the end of my lecture. This is my last slide. Please remember to evaluate CVD risk of our patients at baseline and at every follow-up visit, since this would enable us to provide timely and effective interventions to prevent serious cardiovascular disease among our patients. So thank you for listening. That's the end.
Thank you so much, Dr. Janice. That was a very concise yet practical lecture on how we should manage our patients with dyslipidemia. And actually, I think I am, at least in my personal practice, seeing so much dyslipidemia in young people that it is quite shocking for me to discuss with them the ramifications of not taking care of their cardiovascular status. I've also had seen young patients below 40 have MIs and strokes below 50 years of age. So talagang this is a serious issue that we should be more proactive about.
Our next speaker is going to talk about HIV and aging. Sorry for the slide that is being cut off. She is a resident physician from of the geriatric medicine in Tan Tock Seng Hospital in Singapore, and has been a clinical teacher in Lee Kong Chian School of Medicine and a clinical faculty of U Yong Lu Lin School of Medicine. And she finished her internal medicine residency program at the University of the Philippines, PGH. Let's all welcome our expert, Dr. Jennifer Abengania Van Tersviska.
Ang hirap at sa mga Rod, okay ba yung projection mo from your... Let's see if you have no cut-offs from Dr. Jen's line. Kasi if you do, then I'll present from my computer.
Yeah.
Ayan, okay, perfect. Sige.
All right, thanks. Okay, some disclosures first. Yeah, I'm a batchmate of Kate. Coerced to do this. Can you hear me, guys?
Yes, we can hear you loud and clear.
So I'm currently practicing in Singapore, geriatrics mostly, but I'm not an HIV expert. I have no affiliations whatsoever to disclose. So this is our outline for today. Hopefully I'll run through it quite fast. And next slide. Some abbreviations I may use, most of you will likely know them already. In particular, it's just the highly active antiretroviral therapy. I will be stating it as HART. Okay, next slide, please. So HIV in older adults, actually, it was initially limited to those who had tainted blood transfusions. However, there's an increasing number of older adults with HIV, partly due to sexual activity and improvements in treatment, leading to a larger population aging already with the HIV infection. So in particular, so US has a lot of studies. So they were able to note that approximately 10% of all those diagnosed with AIDS, newly diagnosed, are actually about 10%. And because of the successful viral suppression, HIV is now deemed like a chronic disease. So nearly half of the expected 1.5 million people living with HIV will be aged 50 years and older. So while life expectancy among those on HART has increased dramatically, it cannot be said as normal. Middle-aged and older adults with HIV are not typical of the general population because of a number of things. For one thing, there are studies suggesting that they have premature aging of the immune system. In one study in particular, I think it was in 2008, the SMART study, they showed that there's increasing levels of immune markers among HIV patients. Additionally, there are high rates of depression and suicide and substance abuse among this population. And often, many of these patients are actually estranged from their families and friends due to the stigma. Hence, they have a very fragile social network. So they may be experiencing an array of non-AIDS conditions associated with HIV infection, HIV treatment, and or behaviors and conditions typifying those with HIV. So there are barriers to initial diagnosis and care, one of which is the non-disclosure of sexual activity and orientation. As you know, it's very difficult to ask someone older than you about their sexual preferences, how they're doing their sexual activity. So for older adults, it's quite difficult to elicit this history. Also, there are non-specific symptoms leading to misdiagnosis or even delay in the diagnosis of AIDS or HIV. Healthcare providers, such as us, often underestimate the risks of HIV infection and transmission, partly due to ageism, and which leads to an overall general lack of HIV awareness and knowledge among the older population. And for younger people, there is still the stigma of testing. Next slide, please. So what's the relationship between aging and HIV? So what they say is that aging naturally weakens the immune system in a process called immunosenescence. Immunosenescence essentially is the accumulation in the immunologic space of memory and effector cells because of constant stimulation from repeated clinical and subclinical infections, as well as continuous exposure to antigens. So basically, you're in a state of chronic inflammation. So it makes your immune system quite weak. Also, particularly in postmenopausal women, there's reduced mucosal and immunologic defenses, as well as changes in risk-related behaviors in older adults, leading to increased risk of acquisition and transmission of HIV. As you know, they're not afraid of getting pregnant anymore and all those things, so they may not be doing safe behavior in terms of sexual intercourse. Also, comorbid conditions are more likely to exist among older adults, such that new onset AIDS may progress quite rapidly in this population. And as you've heard from Dr. Caoili's lecture, the interaction between aging and HIV often is frequently manifested by an elevated risk for certain comorbidities, such as the cardiovascular risk. You may have this higher risk of dyslipidemia, MIs, liver disease, kidney impairments, non-AIDS cancers, osteoporosis, and such. But for one thing, I wanted to sort of like highlight the relationship between frailty and HIV. So frailty, if it may not be, it's actually very popular now in terms of when you're talking about GERD patients. It's a clinical syndrome associated with decreased physiologic function and reserves, and often associated with increased risk of disability and death. And this is found a lot in the aging population. The phenotype for frailty is actually popularized by Linda Fried, and it consists of weight loss, unintentional weakness, exhaustion, slow gait, and low physical activity. So these symptoms are actually very prevalent in HIV-infected older adults and affects patients with HIV earlier than those not infected. However, how best to measure frailty among those with HIV is still being debated. HIV, apart from the problems of aging, so in aging there are age-associated changes in physiologic reserve, which unfortunately HIV infection intensifies. So it increases the risk of being frail. HIV itself is an independent risk factor for frailty, but conversely, frailty is quite prevalent in those with HIV. And frailty is different from the HIV wasting syndrome that you may see in some of your acute cases. Next slide, please. So in older adults, the clinical presentation of an HIV infection can be quite nonspecific and often dismissed as age-related. So if you can look at the list of presentation, right, it's very nonspecific. You may actually miss out on the fact that the patient is having HIV, which was why a US study consensus actually advocates routine screening of all older adults regardless of age or individual factors. Next slide, please. So for older people, there's not much difference in terms of managing older adults and younger adults. To prevent and reverse functional compromise and frailty, if possible, patients should be started early on the highly active antiretroviral therapy combined with behavioral interventions to improve adherence, motivate decreased alcohol consumption, encourage smoking cessation and discontinuation of illicit drug use, avoid obesity, and support exercise. To be frank, if older adults are treated with HAART, antiviral response is actually similar to young adults. So meaning they may have similar HIV-1 RNA suppression. And older adults are actually more adherent to therapy. However, more immune reconstitution is less robust in older adults. So they have slower improvement in CD4 count. So when I look through the current guidelines, usually, at least here in Singapore, a lot of it is we based from Western countries like US. They do recommend a few things. So for one thing, they recommend that patients be under the care of ID specialists because there is a need to attend to the prevention of cardiovascular disease among older patients on HIV therapy. They may also require a co-management with the geriatrician only because of the following. So the age-related comorbidities are pretty common and they may present earlier, even a decade earlier among HIV-infected individuals. Also, older adults are more susceptible to certain complications such as encephalopathy, and older adults are also likely to have multimorbidity that may increase the complexity of care and potential for medication interactions. Next slide, please. So in particular, I wanted just to share about the HIV-associated neurocognitive disorder. The spectrum can be from being asymptomatic to frank HIV-associated dementia already, which is an AIDS dementia complex. Usually, this is seen in patients with advanced disease without virologic suppression and is characterized by cognitive deficits, behavior and mood changes, and impaired motor function. I have to say it's quite difficult to differentiate the symptoms from other types of dementia, such as Alzheimer's, unless there is high index of suspicion for HIV or the HIV status of the patient is already known. So the main therapeutic approach, though, remains to be antiretroviral therapy. Next slide, please. So since for older adults, now you're a bit worried, right? You have this older patient coming to you with HIV. How do you know that you are providing more benefit than risk? Because for older patients, admittedly, treatment always comes at a cost. So there is an index that you can use. So it's a comprehensive approach to estimating the burden of the disease experienced by the patient with HIV infection, and it identifies organ systems at risk. So I'm talking about the Veterans Aging Cohort Study Risk Index. You can download this actually in Google. It's quite free. It is helpful because it is more predictive. So it discriminates actually mortality among those initiating HEART better than an index restricted to just checking CD4 count, HIV RNA, AIDS-defining illnesses, because it incorporates a few other things like age, hemoglobin, the fibrosis for index for liver fibrosis, the patient's creatinine clearance, also renal function, presence of hepatitis C virus. So all these things put together can actually predict all-cause mortality, HIV-specific and non-HIV causes of death, hospitalization, fragility fractures, functional performance, and possibly even neurocognitive performance. Okay, next slide, please. So I was just looking through the American Academy of HIV Medicine, along with the AIDS Community Research Initiative of America, supported by the American Geriatric Society, actually came up with a consensus project in 2011 on when to initiate antiretroviral therapy in HIV among older patients. In 2011, so when this first came out, they actually, so it was a panel. They wanted to provide the best possible guideline in terms of handling older patients, because I think it was only in 2011 that really the number of older patients with HIV was increasing. So they suggested to initiate in all patients older than 50 years old with CD4 count less than 500 cells the antiretroviral therapy. They also suggested that maybe in those 50 years, regardless of CD4 count, you may want to start therapy if they have AIDS-defining illness, HIV-associated nephropathy, chronic hepatitis B virus infection. Next slide, please. So for patients, however, there may be patients who may have a CD4 count of more than 500 cells. What they say is you may still consider ART if the patient has the following. So plasma HIV RNA levels greater than 50,000 copies, or there's a drop in CD4 counts about 100 points in 12 months, or there are risk factors for cardiovascular disease, because as Dr. Caoili mentioned, there is an increased risk of this cardiovascular disease among HIV-infected older adults. Okay, next slide, please. However, I also looked at the US Department of Health and Human Services guideline. This was published in 2016. They actually recommend for public health safety likely, they recommend that for all patients, regardless of their CD4 count, if they tested positive, they should undergo antiretroviral therapy. This is essentially because it is an illness that you can have a successful viral suppression. And it is especially important for older patients to start early because of the greater risk of non-AIDS complications and potentially blunted immunologic response to ART. Most benefit would actually be for patients who are 45 to 65 years of age. And the choice of ART would be dependent on the medical conditions and the chronic medications that the patient is taking. Okay. In terms of the cost, as they say, since you are more likely to have, because it's becoming a chronic disease already, HIV infection, you may have more non-AIDS complications. However, there's insufficient evidence to alter current recommendations for the management of dyslipidemia or cardiovascular disease by specific age criteria. So you just basically try to follow like what Dr. Caoili mentioned about how to manage dyslipidemia, and it's reasonable to recommend the Framingham Risk Score assessment in addition to aggressive primary prevention for cholesterol and blood pressure abnormalities. So this requires further study. Next slide, please. So this one, just to share with you some, so because it's, we are going towards, so for primary care guidelines for older adults with HIV, there are some suggested measures that you can do, or you certain things that you can actually order for your patients, especially when you see them at baseline and regularly. So for HIV related testing, some of the things that you can do at baseline is your HIV serology, CD4 HIV, viral genotypic testing. For the cardiovascular risk factors, of course, you should, at baseline and every 6 to 12 months, you should check their blood pressure, their fasting blood sugar, their lipid profile, their weight, and their tobacco use assessment, because these are modifiable risk factors. Next slide, please. So others, as you can see, for older patients, they are at risk of osteoporosis, or they may be having aortic aneurysm. This should be considered. This should be considered to be screened at during baseline. Neuropsychiatric disorders are also pretty common in older people, so dementia screening and screening for cognitive deficits should be done at baseline and annually. For cancers, it depends on their age and their risk factors. Yeah, so just sharing others. So check for other sexually transmitted infections, and also make sure that since our older patients have multimorbidity, it is very important to make sure that you check for any medication toxicity. So for older adults, it is also important to remember routine vaccination. So I think this is not just for HIV infected individuals, but also just for your relatively older people. So make sure that they have influenza, pneumococcal, Hep B, DTP, with a booster every 10 years. In terms of Hep A and meningococcal, it's dependent on risk factors. So a caveat. So I've been talking about older adults, right? Actually, when AIDS and HIV information sheets say older adults, they usually mean those who are more than 50 years of age. Technically, geriatric patients are more than 64 years of age. So this is uncharted territory, basically. Managing, if you have an older adult who's more than 65 years with chronic HIV infection or new onset HIV positive status, this is basically something that is new and uncharted. But there are lessons to be learned in geriatrics. They do say that you cannot just blindly apply guidelines developed for those who are free of comorbidity to those with complex chronic disease and multimorbidity. It is very, very important that you prioritize and tailor the care for those aging with HIV based upon a careful assessment of the risk of morbidity and mortality, identification of their modifiable risk factors, and the related goals of care, and to target your interventions based upon this assessment. There is also emphasis on looking at syndromes and severity of disease over particular diagnosis, meaning it may be more important to identify which organ systems are likely to be at risk rather than labeling all the diagnoses present in an individual. And for older people, the importance of advanced care planning cannot be overemphasized. So prognosis, for if you have an older patient who may have an untreated HIV infection, they are likely to have a rapid downhill course because of impaired T-cell replacement and impact of multimorbidity. So older adults with advanced HIV infections are likely to die within a year of diagnosis, 14 times more than those whose infection were caught pretty early on. As heterosexual activity is the primary mode of infection among older adults, it is very important that you try to engage them in educational programs aimed at ensuring safe sexual practices, as well as increasing their awareness of benefits of testing and effective HIV therapy. They say that you should at least do an HIV screening at least once among 13 to 64 years of age, and annually probably if they remain at risk even after age of 65. So HIV prevention is rarely discussed in geriatric community. So it's high time that we break that barrier and talk to our patients about HIV infection and other sexually transmitted disease. As a special mention for the LGBT older adults, many of them would actually benefit from routine sexual history taking as well as risk reduction counseling. In US, they did a study, so they wanted to know how many of their LGBT older adults remain sexually active, and apparently more than half of those 65 to 75 years old are still very active, and a fourth of those 75 to 85-year-old remain at risk. So most older adults, as I said earlier, they are less likely to use condoms. They're less afraid of getting pregnant. So they're less likely to have been tested for HIV. So that's why the risk reduction counseling is very, very important. Yeah, so actually that's the end for me. So break the bias and the stigma. Let's talk to them about sexual health, STI, and HIV.
Thank you so much, Dr. Abinganya Van Terwisia. I think you have broken the barrier. No, actually, I think this is the first time we have discussed HIV in the elderly, honestly. So congratulations on giving our first talk on that. And because we have been seeing improvements in HIV care among our younger population, we are expecting to be with them as they grow older, and therefore we have to get ourselves ready.
Yeah.
Okay.
Just as a warning though,
yes.
Because I think the only thing is, I think back home we are not so aggressive in terms of checking to see if our patients are actually remain lucid or remain rational. Because some of them may just say, no, I don't want. But they're actually not able to understand so you have to make sure that when you're laying out their options, you're giving them the scenarios properly, the risks and the benefits, and that they can relay it back to you that okay, I understand this is what's going to happen to me if I don't take it. This is going to happen to me if I do take it. They have to be able to relay it back to you to make sure that they actually understand their illness and the therapy that they want to pursue. That so it's just that thing, just to make sure that they really can relay back to you when they're talking to you about therapy and all those things, that they can understand fully what you're telling them.
Yes, that's a good point. Actually, we will discuss further the neurocognitive decline of our patients next session when we discuss with Dr. Anakan, our neurologist. So itong topic about lucidity and dementia of our patients will be explored further along. Now, for the last 5 minutes of our session today, we would like to ask back Dr. Caoili to answer some of the questions that our audience typed in. Rod, can you kindly honor it?
Okay.
Doc?
Yep.
Pwede ako mag-butt-in?
Yes.
Ayun. Ay, Doc Janice. Si Doc Kate po.
Okay.
Doc Kate and Doc Jenny, according to the latest comparative report, the total life expectancy is 69. For men, it's 66, and for a female, 73.
For non-HIV, right?
Thanks for the update. So, yung age ng pasyente ko kanina, 69. Kaya siguro worried siya. Ano pang dadagdag natin? In the theoretical case natin.
No, I think that's general population.
Yes.
But we have, in our setting, like in Makati Medical Center, we have a lot of geriatric cases. And thank you, Jenny, for your talk. I think it's really important that we really understand the needs of the geriatric population. And as you mentioned, we really expect more patients to get older with the disease. So thank you for your sharing regarding management of elderly patients.
Doc Kate, you wanna give the question from one of our three?
Sure. The first is from our colleagues in Las Piñas. Regarding statin-induced diabetes, do you recommend low-dose statin or use less potent statins like pravastatin for those with pre-diabetes?
Okay, so regarding the statin-induced diabetes among HIV, we still need really more information about that. So the guidelines actually recommend that we manage our cases, how we manage non-HIV cases. So we just make sure that we determine if they have diabetes at baseline, and then we monitor the sugars during treatment. So they don't really recommend, decreasing the dose of the statin, because, for example, the patient is on efavirenz, and as I mentioned earlier, the dose of the statin might have to be increased because the effect of efavirenz is to decrease the available statin, for in the blood, or the levels of statin will be decreased. We need really to target. We may need to use higher doses of the statin. And regarding the use of pravastatin, I think because our colleague has information that pravastatin has lesser interactions with ARTs, no? Pero ang goal pa rin talaga natin is to get the targets, the LDLC targets, and there's really no recommendation to use pravastatin over the other statins that are available. Of course, we always have to consider the cost efficacy, no? So ano yung mas available sa atin, ano yung mas affordable sa patient, and also what they can maintain, because some patients may need to take the statins for a period of time. Regarding the other question,
the other question is, can ART affect thyroid hormones and eventually affect serum triglycerides?
So there are also studies showing that hypothyroidism is common among HIV patients, and this was actually seen prior to the advent of widespread use of ART, because hypothyroidism was actually a consequence of opportunistic infections. But now that we are using more ART, hypothyroidism from opportunistic infection is not very common anymore. There were older ARTs that actually affected the thyroid hormones, and we don't use those anymore. Okay, so however, of course, we have to still monitor our patients' thyroid hormones if clinical symptoms are suggestive of hypothyroidism, and if the lipids cannot be controlled, and you think that one of the reasons is hypothyroidism, then you have a reason to check for the thyroid hormone levels. Okay, so as you mentioned, lipid levels can be due to hypothyroidism. So if the patient also presents with symptoms of hypothyroidism, then you are warranted, or you actually have a reason to check for the thyroid hormones of the patient.
Okay, thank you, Dr. Janice. That's very enlightening. I haven't really seen any hypothyroid in my case. I do have hyperthyroid. Hyperthyroid. I think because of the effectiveness of the ARV, as you mentioned, hindi na siya nakikita kasi nga OI-related yung hypothyroidism.
I'm not also sure, Kate, because in New York, when we had our rotation there, a lot of the patients were on thyroid hormones. And then I'm not sure if it's race issue. I don't know. I don't. But
let's investigate.
I agree with you. I don't see a lot of hypothyroidism, but it's also maybe because we don't test.
Correct. So, symptomatic.
Yes. So we only test when they're symptomatic. But I think it's if we have a reason to test, then we can test the thyroid hormones of the patient.
Agree. Okay. So thank you so much for answering those questions from the audience. So guys, overtime tayo. Sorry po. Maraming salamat sa ating dalawang expert. Nag-enjoy ako ng sobra with our discussion today. This is the continuing series of our taking care of our patients beyond our opportunistic infections and really managing their long-term care. So we will like to thank our experts, Dr. Abengana Evangelista from Singapore and Dr. Janice Caoili from Makati Med. Maraming salamat sa ating mga participants. Thank you for listening and spending your time with us. You may now answer your post-test.